Our first speaker is Dr. Soumya Krishnan. Dr. Soumya graduated from medical school, Maulana Azad Medical College in New Delhi. She completed pediatric residency at Harley Medical Center in Flint, Michigan, completed pediatric endocrine fellowship at the University of Oklahoma Health Sciences Center. She is currently the program director for pediatric endocrine fellowship at the University of Oklahoma. Dr. Krishna's interests include children with endocrine side effects of cancer treatment, diabetes, bone health in children, including metabolic bone disease of prematurity, bone health in diabetes, bone health in obesity. Dr. Krishna will be speaking to us on pediatric osteoporosis, recognition and management. Dr. Krishna, thank you very much.
Thank you for the kind introduction, and thank you to the organizers for giving me this opportunity. Let me share my screen. Today, I'm going to talk about pediatric osteoporosis, recognition, and evaluation and management. I'm having some difficulties. Hold on. I'm not able to. We have too many. So the disclosure, sorry about the technical difficulty. So for disclosures, I did get grant support from Alexion. I do not have any commercial support for this presentation. And I'll be discussing use of bisphosphonates in pediatric osteoporosis, which is pretty off-label for most diagnoses other than osteogenesis imperfecta. The primary objective for my study is to 1, recognize pediatric osteoporosis, 2, plan preliminary investigation for children who present with bone fragility, and evaluate these results to discuss further management. Before we get started on the presentation, I would like to discuss 3 cases just to kind of ground our presentation and think of the recognition, evaluation, management in terms of clinical practice. And while I discuss these 3 cases, I would like you to think of these 3 questions. 1, does this child have pediatric osteoporosis? 2, what further investigation would we do? And 3, what therapy would we recommend? So case 1 is a 9-year-old child with known history of osteogenesis imperfecta, who is seen in our clinic.
I apologize for interrupting. We just want to make sure that the online and the in-person audience have the correct visual. So I'm going to have you stop sharing your screen. All right. And then you want to share your screen one more time, and we're going to have you select the correct view.
Should be one with the full screen PowerPoint.
Is this good?
No, if you go stop and then do that again, there should be a screen that just shows the one slide from the PowerPoint, like a full screen version of the PowerPoint when you go to share screen.
Okay. Is this good?
Yes, I'm sorry for the interruption. Please continue.
Okay, I apologize for that. Okay, so let's start off with case 1. And this case 1 is a 9-year-old child with known history of osteogenesis imperfecta, who is seen in our clinic for the first time. Family moved from a different state. The history reveals that he received an infusion for 2 years when he was 3 years old for lower leg fracture. Now he has rods in both the legs. He has not suffered from any other fractures since then. He does have back pain for the past 6 months though, and he's getting physical therapy for this. Mom has a history of osteogenesis imperfecta herself too, but has not had any fractures for past several years. So, okay. Case 2 is a 17-year-old child with global developmental delay, spastic quadriparesis, who is non-ambulatory and is referred to you because he had a fractured left femur when parents tried to change his diaper. Parents heard a snap and they brought him to ER as they felt he was uncomfortable. X-ray leg revealed femur fracture. Case 3 is a 10-year-old child with Duchenne muscular dystrophy who is referred to you because he had a forearm fracture when he fell on playground. He has been on prednisolone treatment since diagnosis at 2 years of age. Current regimen consists of 20 milligram prednisolone once a day, every other day. This is the first fracture he has had that he knows of, and he has never had a bone health evaluation done in the past. So what is osteoporosis? Osteoporosis, as defined by NIH consensus statement, is a skeletal disorder characterized by compromised bone strength, predisposing to an increased risk of fractures. It is a worldwide epidemic with increasing incidence over the past few decades. How does pediatric bone health relate to adult osteoporosis or adult bone health? To understand that, we have to understand two key concepts. One is attainment of peak bone mass, and the second is tracking of bone mass during childhood. So as a child grows, there is accrual of bone mass with age until a child reaches full genetic potential peak bone mass at around 20 to 25 years of age at young adult age. This then serves as the bone bank account for the individual till, when they get older, if there is additional insults, or for a female, when they hit menopause, the bone mass can decrease. That leads them to have increased risk for osteoporosis. If there is inadequate environmental factors like systemic insults, systemic disease, medications that interfere with bone mineral accrual, this peak bone mass is suboptimal, which places them at higher fracture risk when they get older. Also, studies have shown that BMD Z-score tends to track with age. So this shows over a period of 3 years, the child who starts off with a BMD Z-score of -2 continues to be at a lower BMD Z-score after 3 years of age. The mean difference between each of these groups continue to be significant at all time points. So a child who starts off with a higher BMD Z-score stays at a higher BMD Z-score, which tells us the importance of optimizing bone mineral accrual at this age. So what is pediatric osteoporosis? Per the 2019 International Society of Clinical Densitometry, ISCD statement, pediatric osteoporosis is defined by the presence of vertebral fractures. In the absence of vertebral fractures, clinically significant fracture history and a BMD Z-score of less or equal to -2 is required to diagnose pediatric osteoporosis. And when we mean clinically significant fracture history, it typically means 2 or more long bone fracture by age 10 years or 3 or more long bone fractures by 19 years. These typically relate to fragility fractures, and fragility fractures typically are if you fall from a standing height and there's not a much significant trauma involved. You can diagnose pediatric osteoporosis even if the BMD Z-score is above -2. The more important criteria is to have a significant history of bone fragility fractures. So what is the etiology of pediatric osteoporosis? They can be broadly classified as primary bone disorders like osteogenesis imperfecta, idiopathic juvenile osteoporosis, osteoporosis pseudoglioma syndrome, or it could be secondary disorders which influence bone health, systemic diseases or systemic treatment with medications that influence bone health. And those are multitude of diseases These include chronic inflammatory disorders like inflammatory bowel disease, JRA, celiac disease, cystic fibrosis, immobilization resulting in poor bone health like cerebral palsy, myopathic disease, endocrine diseases like Turner syndrome, anorexia nervosa, type 1 diabetes, cancer, especially acute lymphocytic leukemia, has been well recognized to adversely affect bone health, hematological diseases, thalassemia, sickle cell disease, drug-induced, which typically is glucocorticoid-induced osteoporosis, is very well recognized. While in this presentation, I will not touch on every aspect, every cause of pediatric osteoporosis, we will discuss some generalized approach to management. So evaluation for poor bone health. If a child gets referred to you for poor bone health, what do you start off doing? First, it's very important to get a good history, especially fracture history, which bone, and if it's really just a minor metacarpal metatarsal fracture compared to a long bone fracture, holds different implications. The trauma associated with the fracture. History of back pain may give you a clue about possible vertebral fractures. Does this child have any systemic disease that can influence bone health? So poor past medical history. History of medication use, including long-term glucocorticoids. Family history of primary bone fragility disorders like OI. And even a good review of systems may give you a clue, like what is the pubertal status, pubertal progression, abdominal pain for possible celiac disease or other inflammatory bowel disease. Physical examination will include looking for blue sclera dentinogenesis imperfecta, for example, as clues for OI. Very important to look at pubertal status of the child. So the preliminary bone health workup can be broadly thought of as laboratory workup, which will include bone health labs, 25-hydroxyvitamin D, parathyroid hormone, calcium, alkaline phosphatase. Labs to look for a secondary cause of low bone mass, including celiac panel, thyroid function, if the signs and symptoms suggest that. Pubertal hormones, again, if you're suspecting delayed puberty, homocysteine levels, if there is increased flexibility noted on examination. Other important part of preliminary bone health workup includes spinal fracture assessment and bone density measurement. And we'll talk about these two in slightly more detail. So spinal fracture assessment is an integral part of evaluation for a child with suspected poor bone health. If present, it makes the diagnosis of pediatric osteoporosis. This spinal fracture can be assessed by looking at the lateral spine X-ray or by using DEXA scan to do vertebral fracture assessment, CT scan, MRI, or other modalities that can be used to look for spinal fractures. This is a quick table that shows you what are the pros and cons of different modalities used to look for spinal fractures. DEXA vertebral fracture assessment has the lowest radiation and has the least cost, but it does require some experienced technologist, and you need a special machine which can do the vertebral fracture assessment software, I should say, that can do this. X-ray, lateral spine X-ray is easily available. Radiation is slightly higher than a DEXA scan and can be, of course, more costly, but the resolution is supposed to be better than a DEXA scan VFA. CT scan, MRI, of course, have great resolution, but the cost, they're much more expensive. And of course, CT scan has much higher radiation. I want to talk quickly about this Genant semi-quantitative methodology, just to kind of tell you that this is a term that you may see when you read the literature on pediatric osteoporosis and vertebral fracture. This is a methodology that's often used to grade vertebral fractures and to follow the resolution with time. So, and this methodology uses an amount of loss of vertebral height to grade fracture as mild fracture, moderate fracture, or severe fracture. Mild fracture is 20 to 25% loss of vertebral height, while moderate fracture is where there is a loss of 25 to 40% of the vertebral body height. And a severe fracture is when there is more than 40% loss in the vertebral height. These fractures can be either wedge fracture, where there is just loss of height in the anterior aspect of the spinal vertebral body, or biconcave fracture, or a crush fracture, where there is loss of vertebral height in the posterior aspect of the vertebral body. So bone density measurement by DEXA. This is part of the comprehensive skeletal health assessment. DEXA is the preferred method for measuring bone density. At this time, the ISCD guidelines states that you should get DEXA scan in patients with primary or secondary bone diseases when patients may benefit from interventions, and DEXA results will influence management. Preferred site to get DEXA scan is at the lumbar spine and the total body less head in pediatrics. I think this was briefly alluded to at Dr. Weber's lecture too, but this is very important to understand that DEXA scan is a two-dimensional projection of a three-dimensional object. So what DEXA scan really gives us the aerial bone density. So the DEXA scan can misinterpret bone mineral density in smaller subjects due to smaller size of bones. Another important thing to remember is that data cannot be cross-interpreted between different machines. So if you get a DEXA scan in a hologic machine and then 1 year later you get it in another machine, you can't really compare those two BMDs. And the DEXA scan does not distinguish cortical or trabecular bone density. So these are two different size bones. It's a pictorial representation of how the size of the bones influence bone mineral density. So a smaller bone measuring 1 across 2 across 1 centimeter, while the bigger bone measures 2 across 3 across 2 centimeter. The mineral mass here is 2 gram. Mineral mass here is 12 gram. Volume is 2 centimeter cube. Volume is 12. The projected area is 1 centimeter square, while here the projected area is 4 centimeters square. Volumetric bone mineral density for these two bones are the same at 1 gram per centimeter cube. But the aerial bone mineral density, that which is measured by the DEXA scan, is less in a smaller bone, is 2, while in a bigger bone, it's 3. So this tells you that, when we use DEXA scan to measure aerial bone density, we may be erroneously classifying smaller children or shorter children with low bone mass or pediatric osteoporosis. So it's important to recognize that caveat. Other pros and cons of DEXA scan is that DEXA scan is easily available. It does have very low radiation doses, and most published literature uses DEXA scan as measure of bone health. Cons is it measures aerial density. Age and gender-based normative data is still not strong. It needs to get more robust. Now, there is a huge racial difference in bone mineral density. So this graph shows how bone mineral density is much higher in African American children compared to white children for the same pubertal stage. So it's very important to base your Z-scores on age, gender, as well as race. A quick thing about a T-score and a Z-score. I'm sure I'm preaching to the choir, but again, this is very important. T-score compares a patient's bone mineral density to gender-matched young adult, and it's primarily used in postmenopausal women. Z-score compares patients' bone mineral density to age and gender-matched normative data. And of course, there is, we got to remember that there is limited availability of normative data in children less than age 5 years. So for example, if you measure the bone mineral density in an 11-year-old child, comparing the bone mineral density to other 11-year-old age and gender matched and race matched children will generate the Z-score. While if you compare this child bone mineral density to an young adult bone mineral density, that will generate a T-score. Now, as you can see in a growing child, comparing the bone mineral density to an young adult will misleadingly label everybody as osteoporosis. So it's very important to avoid use of T-score in pediatrics. There are published ways to correct for size. This is a ZScore calculator from the CHOP group that's available in the website, where you can enter your BMD and it will correct your BMD for height ZScore. But this is available only if you do BMD in a hologic machine. If you use other machines to measure your bone mineral density, you have to look for either correction for height, age, or maybe pubertal status. There are other tools to measure bone mineral density, including QCT ultrasound, but those are really not often used in the clinical realm. Remember, age-related norms and fracture prediction are strongest with DEXA measures, sorry. So we talked about evaluation, recognition, evaluation. Now let's come to management. Sadly, we don't have too much in our armamentarium to manage children with pediatric osteoporosis. Of course, vitamin D and calcium replacement. Bone health is influenced by a multitude of factors. Of course, one of the big components is genetics, then calcium and vitamin D replacement. Now, different societies have different recommendations for target vitamin D levels. Institute of Medicine recommends anything above 20 nanogram per ml to be optimal for bone health. Now, assays to measure vitamin D, remember, should include both D2, D3. We don't necessarily need to know those values. It's just important that it measures, because both of them contribute to the D values. And liquid chromatography mass spec is the most accurate way to measure vitamin D levels. Other factors that influence bone health include weight-bearing exercises, optimal body weight. Medications can have an adverse effect on bone health, and other lifestyle factors, general health, nutrition, and hormonal status. This is an Institute of Medicine recommendation on calcium intake, recommended calcium intake, and the recommended vitamin D intake in children at different age groups. Apart from calcium, vitamin D, weight-bearing exercise, the other thing that often is used in children with pediatric osteoporosis is bisphosphonates. Bisphosphonates are anti-resorptive agents. It causes inhibition and apoptosis of osteoclasts on surface of bone. There is still not a uniform approach to the use of bisphosphonates as in regards to drug, dose, duration. But I will give some overarching themes and guidelines regarding bisphosphonate use in children. Intravenous bisphosphonate are considered more efficacious in treatment of pediatric osteoporosis. So oral agents are not recommended at this time. The consensus is to use bisphosphonate when a diagnosis of pediatric osteoporosis, as defined by ISCD or clinic, is when they meet the diagnosis of pediatric osteoporosis after ruling out secondary cause of low bone mass. The bisphosphonates closely resemble the structure of pyrophosphate. The bisphosphonate form a PCP structure, and they differ in the R group, the two R groups that are attached to the C atom, while the pyrophosphate has a POP structure. This is a study from Cincinnati where they looked at their data on the use of bisphosphonate in the past 7 years, and showed that most of the bisphosphonate used was for children with primary osteoporosis, including juvenile osteogenesis imperfecta, juvenile idiopathic osteoporosis, osteoporosis pseudoglioma syndrome. The other big group was for secondary osteoporosis, which included disuse osteoporosis and other chronic diseases. 24% of the bisphosphonate use was for glucocorticoid-induced osteoporosis for various other systemic conditions. Bisphosphonates do have side effects. The most common side effect is acute phase reactions, and the acute phase reactions usually consist of fever, myalgia. This is seen with both use of pamidronate and zoledronic acid, which are the two bisphosphonates that are often used. It's more often seen in a diagnosis of secondary osteoporosis than the primary osteoporosis. And it's slightly more common with the use of zoledronic acid. It's also more common with the first infusion and gets a little bit less frequent with subsequent infusions. Studies have shown that if you start bisphosphonate use and you stop it before completion of growth, you can have fracture at the site where there is new bone formation. And the new, because the new bone here is not exposed to bisphosphonate. So you really have fracture at the site where the bone that is exposed to bisphosphonate meets the bone that has not been exposed to bisphosphonates. So at this time, the consensus is that once we start bisphosphonate, and continue it till the child completes growth. Also, studies from Montreal group have shown vertebral body remodeling with bisphosphonate use. This is a radiological picture of a vertebral bodies, which shows compression fracture. And after bisphosphonate use, you can see how with growth, the vertebral body height is getting better, though it may not be completely normal. There's a big resolution in the fractures. So really beautiful studies that show the benefit of use of bisphosphonates, especially if there is vertebral body fracture. Now I would like to go back to the cases and discuss what we decided to do. So if you remember, case 1 was a child with known history of osteogenesis imperfecta. He did have some history of lower leg fracture. We're not sure, maybe 1 or 2, but he has rods. He has not suffered from any other fractures, but he does have back pain. So what did we do? Does this child have osteoporosis? Now, he just had 2 long bone fractures. And if you look at the ISCD guidelines, he may not meet the definition of pediatric osteoporosis at this time. But we did further evaluation that included a DEXA scan, which did show a very low BMD Z-score of -3 at lumbar spine, and total body less head was -3.5. He had normal vitamin D levels, 25 hydroxyvitamin D levels. And the spine X-ray did reveal multiple vertebral body compression fracture. I hope you can see this loss of height here. So we did start him on bisphosphonates, and he did have the back pain and the vertebral body fracture, which was the reason for his back pain. So case 2, if you remember, was a 17-year-old child with global developmental delay, a spastic quadriparesis, non-ambulatory child who had a fractured left femur just when parents tried to change his diaper. So really very, very minimal trauma. So what did we think? Does this child have pediatric osteoporosis? Now, it's very difficult to break a femur. So we would consider this pediatric osteoporosis, even though it's just 1 fracture, but the trauma is so less. What we did for further evaluation, on examination, he actually had not started puberty at all. It was still Tanner stage 1 in pubic hair and gonads. Lateral spine X-ray did not reveal any vertebral fracture. DEXA scan BMD Z-score revealed a low BMD Z-score, but this was unadjusted for height. We did vitamin D levels, which was 28 nanogram per ml, but he did have low testosterone, LH, FSH, consistent with hypogonadotropic hypogonadism. We did further pituitary workup and started him on testosterone replacement. Case 3, if you remember, was a child with Duchenne muscular dystrophy and who was referred to us for forearm fracture. Now has been on prednisolone treatment since diagnosis at 2 years of age. This is the first fracture he has had that he knows of, and he has never had a bone health evaluation. Before I go into follow-up for this child, I would like to discuss briefly about a glucocorticoid-induced osteoporosis. This is increasingly being recognized, and some good trials have shown us the ways to manage this condition. So glucocorticoids have multitude of effects on the bone and have multiple ways in which it affects the bone adversely. So it actually adversely affects all the bone cell function. It decreases your osteoblast function, increasing apoptosis. It decreases osteocyte function, and it actually leads to osteoclast, increased bone resorption too through osteoclast activation. It also influences your neuroendocrine system, thus decreasing growth hormone axis, decreasing the effects of pubertal axis, thus decreasing your sex steroids. It affects your calcium metabolism, and of course, it does cause myopathy and decreased muscle function. All this results in decreased bone quality, decreased bone mass, increased risk of falls, leading to increased risk of fractures. So very nice trial, this top trial, which is steroid-induced osteoporosis in pediatric population, consortium from the Canada group. They followed children with rheumatic diseases over a period of 3 years who have been on systemic steroids. And what they found was that the unadjusted vertebral fracture incidence in this population was around 4.4 per 100 years, with 3-year proportion of 12%. The highest incidence of vertebral fracture happens in the first year, and that's around 6%. The predictors of increased vertebral fracture risk in this population who have received systemic steroids is increase in disease severity, increase in BMI Z-scores actually, and decrease in lumbar spine BMD Z-scores. So based on this data, this is a very good review by Dr. Leanne Ward, which was recently published in Frontiers in Endocrinology. The approach to monitoring and diagnosis of osteoporosis in children, in any child who receives oral or intravenous glucocorticoid therapy at doses above 8 to 10 milligram per meter square per day for more than 3 months, you should look into bone health. And apart from optimizing calcium and vitamin D and encouraging mobility, the evaluation for bone health includes looking for vertebral fracture, which includes lateral spine imaging at baseline annually, and BMD monitoring again at baseline and every 12 months. If you do identify vertebral fractures, your approach to what to do with these fractures depends on the primary condition and how long will these children be exposed to glucocorticoids. So think of it as, will this child get aggressive but transient glucocorticoid exposure? Maybe variable glucocorticoid exposure, you don't know, but depends on how well the primary condition is being treated. Or in certain conditions, this child is going to be on long-term glucocorticoid. They can never come off glucocorticoid. So examples of these conditions are leukemia, where you get glucocorticoids at the induction phase, but then it's going to be stopped after 3 to 6 months. Inflammatory bowel diseases, you don't know how long they will continue steroid. Versus Duchenne muscular dystrophy, you know they're going to get glucocorticoid therapy forever. So based on this, when you kind of get an idea of the primary condition and how long the glucocorticoid exposure is, that will dictate your management. Why is that? So this is a study which showed, in children with, in children with leukemia, have actually a good percentage of children, around 10%, I would say, if I'm remembering it right, have vertebral fractures at diagnosis. And this is actually follow-up X-ray on a child who had vertebral fracture at diagnosis. I don't know if you can see this loss in vertebral height here. The child was started on chemotherapy, and this kind of got accentuated, and you can see the nice loss in vertebral height, crush fractures, biconcave fractures. And then once chemotherapy was stopped, the vertebral height loss stabilized, and with growth and puberty, this actually spontaneously resolved without any treatment with bisphosphonates. But in a child like Duchenne muscular dystrophy, who is going to be on steroids and you cannot take them off steroids, if you identify vertebral fracture, then the recommendation is to start bisphosphonate therapy and to continue at maintenance doses, and of course look for other ways to optimize bone health, including testosterone for pubertal induction. So in our child, what did we do? So the question is, does this child have osteoporosis? We can say that this child is at very high risk for osteoporosis. Maybe it still does not meet the clinical definition as defined by ISDD, but definitely has very high risk for fractures. So further evaluation by us, we did a lateral spine film, which did not reveal any vertebral fracture. We did a DEXA scan, which did reveal a low BMD Z-score of -2.5 at lumbar spine and total body less head of -2.5, which is again, I'm not giving an adjusted for height Z-scores. The lab showed a vitamin D level of 18 nanogram per ml. What we did for this child was we started the child on vitamin D replacement. The plan is to monitor for any other low trauma fracture and also get a DEXA scan in 6 months in this child.
Sorry to interrupt. We are short in time. If you could please highlight.
Okay, I'm almost at the end of the study talk now. Summary, I want to say the pediatric osteoporosis is a clinical diagnosis. Spinal fracture assessment is an integral part of evaluation of child at risk for poor bone health. DEXA scan is a golden tool to assess bone health, but measure when intervention is planned to reduce risk for fractures. Antiresorptive treatment consensus is to use when child meets criteria for pediatric osteoporosis, and in child with secondary osteoporosis, if systemic insult is predicted to be prolonged. I have this metabolic bone disease clinic at University of Oklahoma, and a shout out to pediatric endocrine societies and ASBMR and the Bone Seg group, where we can really have very good networking to learn more about bone health. These are additional resources, and that's it. Thank you.